Now I invite Dr. Senthil Kumar to talk to us about the lessons learned from legal cases. So, as I said earlier, he's been the chairman of the PPLSS scheme, which has been very successful in defending the number of negligence cases in Tamil Nadu. Over to you, Senthil.
Good morning. I would like to thank AIOS and Dr. Nirmal sir for giving me this opportunity. So, this presentation is going to be a summary of what the previous speakers have dealt with. So, without doubt, those were very excellent speeches, and there will be some areas where there will be a lot of crossing overs, just to stress the importance. So, don't mind much about the crossing over areas. So, legal case, it's a dispute between parties resolved by court or other legal process. So, it's a party who feels wrong or has a claim against the other party initiates a process by filing a lawsuit. So, Dr. Murli had already touched upon this thing. Civil lawsuits could be due to breach of contract, civil wrong, that is tort, product liability, so we need to keep that in mind also, consumer litigations. Criminal lawsuits are, it happens when there is a violation of law and prosecuted by the state, which results in imprisonment or fine or both. Sir has given an example of that Trichy case where 2 doctors were sent for imprisonment for a period of 2 years. So, case law, this is more important because these are based on the judicial decisions. Similar case, when a judgment is given by a Supreme Court, that has a binding value on all the courts of India. And accordingly, a judgment given by a High Court has a binding value on all the courts of that particular state. So, legal cases in ophthalmology are due to medical negligence, inappropriate diagnosis, improper communication, inadequate or improper consent, inadequate documentation. Most of these were dealt in detail by the previous speakers. So, common cases in ophthalmology were related to cataract surgeries, corneal surgeries, retina surgeries and ROP screening, squint surgery and insurance related cases. So, like it was pointed out, 3% of the cases in the past 20 years were from ophthalmology, and we need to be mindful that the compensation rates were really higher. That's more important. And that 942 cases were the cases which are filed in the court. Apart from that, there were advocate notices also. The difference is, advocate notice means when you receive an advocate notice, the reply can be given by yourself or on behalf of you, a medical legal consultant, but it should be like as if you are writing the reply, or a lawyer can give a reply. But for a court notice, the reply has to be from a practicing lawyer only. So, these notices were common even with when glass prescriptions were not given to the patient in the OPD after consultation. There were advocate notices and notices given that you had not informed me that there will be a photophobia following a dilatation, so I had met with an RTA. So, this is the place where your general consent has an important role. So, while getting an general consent, tell that in case if needed you will be dilated, and after dilatation there will be a photophobia for around 4 hours and related to that. And while giving prescription, in the prescription there should be a comment on, if there is a steroid, there should be a comment that it should not be used for a longer time. There were cases related to that. A 4-year child was given an steroid treatment, was continuing the treatment till 18 years, landed up with optic atrophy. And comment should be there in anti-glaucoma medication that it has to be continued lifetime unless informed by the surgeon otherwise. So let us see some case studies, cataract surgeries and related complication when there is an unexpected visual outcome, nucleus drop and referral to retina surgeon, PRP laser and field of vision. Squint surgery leading to death of patient. Squint surgery where bilateral lateral rectus recession was done, resulting in an complication of esotropia. We'll get into these cases. So insurance related cases were mostly like wrong diagnosis entered in discharge summary. For example, for LASIK surgery, if you want the insurance approval, the dioptric power has to be more than 6. There we know that to benefit the patient, we will write that refractive error of 7 diopters or so. But in case if something goes wrong, the patient will tell that all my previous prescriptions, the refractive error is around 2 or 2.5. The doctor, in order to mint more money, has given an false diagnosis. You cannot come out of that. So then split up charges. We all know that you will be giving an split up charge for around 40,000 or so, but insurance company will only approve somewhere around 22,000. So the rest 18,000 will be collected as cash or through GPay or other means. What will you do in case if the patient asks for a bill? Insurance company won't allow giving an excess bill, because like he might claim that with that bill what you are giving, he might claim. So insurance company won't allow giving a bill. So in that cases, what we can do is give a bill stating that towards other expenses apart from insurance approval. Or in ophthalmology, we can also do something like bill towards a glass prescription. In case if 18,000 is the excess value collected, you can inform the patient, I cannot give a bill as per insurance. So for you, towards income tax purposes, I will give a bill towards optical expense. That's one option I am giving. So this is an squint surgery where the child was admitted in hospital for squint surgery. Bilateral lateral rectus recession was done with a resultant esotropia causing diplopia. The patient went to another hospital, underwent another surgery, then filed a case against the first hospital that there was negligence. So the case went on, and the doctors could successfully defend, stating that we had advised Prism for correcting diplopia. The patient has not followed our advice, and without our knowledge, he underwent surgery elsewhere. So the point to be noted in this is mentioning the review or follow-up is very important. So we can tell that on this particular date, I had advised the patient to follow up after so and so time. Patient has not followed up. So there is a contributory negligence. So nucleus drop and referral to retina surgeon. This is one common scenario what we see. So there was a cataract surgery, nucleus drop was there, and the patient was referred to a retina surgeon. So after 4 months, patient files case against the first surgeon and the retina surgeon, stating that his visual outcome was not as expected and is under treatment elsewhere constantly for the past 4 months or 5 months. So this case could be defended because like nucleus drop is one of the common complication. Following a complication, the doctor has done his level best, and referral is not a negligence. So the patient has not followed the advice of retina surgeon after surgery, in the sense he has not followed with the retinal surgeon where he got operated. The thing to be noted here is the documentation of the first surgeon and the second surgeon was differing a bit. So that's where we get into trouble. So like Dr. Murli said, you need to document the communication, and the communication needs to be documented. So whatever the first surgeon has said, in case if the first surgeon has documented, like pieces of cortical material were found in the vitreous, then you can write, instead of writing that if you want to protect the other surgeon, instead of writing the whole nucleus is in the vitreous. Instead you can write material of around 7 mm is found floating in the vitreous. Means we know that the nucleus is only going to be of around 7 mm. Sometimes it will be helpful for us while defending the case. So, like it was mentioned earlier, the communication has to be properly documented, and a separate consent in case if you are going for the second surgery, which should mention the risk, benefit and alternatives. PRP laser and field of vision loss. There is a case where the patient has made a litigation that he was not informed. Sir, can I take 2 more minutes, sir?
Yeah, please go ahead.
So, he was not informed that there will be an restriction in the field of vision. So, this case actually got dismissed, and in the due course the patient also died. So, that was one way helpful actually with regard to that case. Yeah, no sir, like few cases the patient has to be there. Here we could state that the patient had so much of complications, and because of the complication the patient has died, leading to other general thing also. So, such is the disease burden. Okay. So, one more case, there is a squint surgery where the compensation was in the tune of 1 crore. 6-year-old child was admitted for squint surgery, and the child died during the procedure. Hospital, anesthetist and surgeon were directed to pay compensation around 1 crore rupees. So, here the cause of death was hypoglycemia and shock related. National Consumer Dispute Redressal has mentioned in the judgment that the negligence was proved due to the following reasons. The fasting time and the last oral intake to the commencement of surgery was higher, somewhere around 9 hours. There was no coordination between the anesthetist and surgeon regarding to adverse drug events, halothane and scoline. Fitness was not given after undergoing necessary investigations, in the sense, initial doctor who had seen this kid has told that there is a murmur, but subsequently another cardiologist has told there is no murmur, so fitness was given. And previous speaker has mentioned that whenever they ask for a document, it has to be given within 72 hours. In this particular case, the hospital has taken more than 6 months to give the case sheet documents. And it was also mentioned that in the discharge summary, the events of CPR were not recorded. On top of it, always there will be an emotional aspect during judgment. So, here that is a precious child since the mother underwent hysterectomy. So, medical negligence is, there are 3 components. There should be a duty, breach of duty and resulting damage. So, resulting damage, I am talking about the resulting damage. Unfavorable outcome doesn't mean negligence always. So, that is informed in lot of judgments, landmark judgments. So, to indicate negligence, there should be material available on record. So, not possessed with reasonable skills which he professed to have possessed, or did not exercise with reasonable competence. So, why I am mentioning that is, so I will come in the later slide. The lessons learned from litigations were documentation, need for documentation, proper communication, proper consent. So, cataract surgery, B scan should be done in mature cataract. There was a case where the compensation was given because the doctor has not done an B scan. Always remember, discharge summary needs to be countersigned by the patient and attenders, telling that we had taken a discharge summary. So why I was telling about not possessed with reasonable skills which he professed to have possessed, or because like Murali sir was talking about that particular case of sonologist, trained sonologist, that he was trained for 6 months, and then he is claiming him to be as a radiologist with MCH degree creeping up in ophthalmology and DNB super specialty courses in retina and other specialties. How courts are going to interpret the skills obtained in fellowships program? This is a question to ponder. And last few slides. So whether CAM surgeries are a thing of the past or it is coming in a different format, hospital on wheel concept. So there are several unanswered questions for a hospital on wheel concept, like obtaining various mandatory license like PCB license, EA certificate, biomedical waste, how they are disposing the waste, sewage treatment, sanitation certificate, etc. In case if some of the patients who is not getting the expected visual outcome goes into a court, will be in trouble. So way forward is following government rules and regulations, adherence to policies, quality of work, focusing on the quality of work, documentation and accreditation. So I have taken one last slide to stress the importance of any accreditation process, be NABH or other things. The case where I said the compensation was around 1 crore, there were few lines in the judgment which are mentioned about the pre-medications which were not discussed between the doctor and the surgeon and the anesthetist, and the OT list which was higher, it was around somewhere around 16 cases in that particular day, but the patient, that kid was kept on fasting for around 9 hours, not mindful of the fact that this hypoglycemia can also be an cause for shock. So it's very surprising to see that whether the judgment was given after going through this objective element. So nicely this objective elements was framed, thanks to Dr. Nirmal Frederick sir, who has nicely framed these objective elements. So I'll just read out that depending on the pre-anesthesia, a plan for anesthesia should be documented. The plan should mention the pre-medications, type of anesthesia, special requirements, anticipated post-anesthesia care where appropriate. This was mentioned in the judgment. The preparation for patient by OT staff are based on the plan of anesthesia signed by the anesthetist. It is also documented in the OT list. So these were the things which are exactly mentioned in the judgment. So as to conclude negligence, and the objective element of COP3C, COP is care of patient 3C, mentioned that the events of CPR should be documented. So again, this particular point was mentioned in the judgment, that the events of CPR were not documented in the discharge summary. So going for accreditation is not for getting the piece of paper that so-and-so center is aggregated, but for improving the quality, and it has to be a journey.
Thank you.
Thank you.
Thank you, Senthil.